Hello everyone and welcome to today's Ellanse webinar on guidelines for best practice in preventing and managing adverse reactions. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio panel in your control pane. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions panel of the control pane. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. The Ellanse safety report, the instruction for use of Ellanse, the adverse event follow-up report form, as well as the publication on Ellanse treatment guidelines and a summary of it are available for download in the handout panel of your control pane. You may download them anytime during the presentation. Please note that the clinical photos in these presentations are for educational purposes only, and they should not be for reuse, keep, or show to other people. I would now like to introduce our two speakers, Dr. Shangli Lin, who is a dermatologist from Taiwan, and Dr. Francisco de Mello, who is a board-certified plastic surgeon from Portugal, practicing in Dubai. Let's move on now to the first presentation by Dr. de Mello.
Hi, good afternoon, everyone. Welcome to this summer webinar on Ellanse, and we're trying to get you some guidelines and what me and Dr. Shangli advise and promote to practice in terms of using of Ellanse and trying to prevent and managing adverse reactions. We'll try to move this as fast as possible with the slides, and please do not forget to have the questions you can come up with, and just let your questions, you try to answer everything in the end. So how we're going to organize is very simple. I'm going to have a small lecture, 20 minutes. Dr. Shangli will do the same thing. And on top and the end, we have some cases to present, and we can move on and try to get your answers and your questions as best as possible. Okay, I'm trying to move my first slide. For some reason, it is not going. I have to ask some assistance here because it's not actually moving. Okay, there it goes. Well, when it comes to facial aging and the use of fillers, I think for the ones who know me, this is the kind of slide I usually use, but I come up with something very simple in this phrase. It is the last part is volume restoration can also improve quality and laxity of the skin. And this, in my opinion, is when we start using the biostimulators. And this is the main reason why you need to do that. And well, that's the advantage of Ellanse, and that's the advantage of the biostimulators when you can use it on these features. I'm sorry, but I'm having a little bit of a difficulty in moving the slides down, so probably I need to get some assistance. Yes, there it goes. So the question is, again, is what is inside the syringe? And well, you know that Ellanse works in two phases. You got a volumizer inside, and you also get the biostimulator, that is the polycaprolactone. So we have 0.7 of carboxymethylcellulose, which is the majority of the syringe. And then you got the polycaprolactone, which is a 30%, and will be responsible for the stimulation and actually to be able to get the volume that you need. That's the responsibility. That's actually the reason why you get a long-lasting results is due just to this 30% that you get from the biostimulation. The next slide, please, if you don't mind. And the secret is how you can get the suspension of spheres inside the gel is so simple in a way, but is fulcral for getting the good results and avoiding bad results and complications, is because the spheres are homogeneous distributed along the gel carrier. So things like that totally off-label and not advisable by the medical board to do, like dilution and mixing this with saline, we change this mixture, and actually you're going to create more chances and more probabilities to get a side effect or adverse effect that you don't want to have. Let's move to the next slide, please. So when it goes when all this is a bit out of tune, the thing is the length of the chain of Ellanse, as you know, and this is what's supposed to be showing in red, tells you how long it'll take to be in terms of result. Because the longer the chain, the more time you need for it to get hydrolyzed, and so you get stimulation for longer time. Is one of the things I never understand really, is why people try to dilute things, because they try to dilute things to make it weaker. And you cannot make this weaker by adding saline onto it, because the only thing you're going to make is changing the gel characteristics, and you're going to lose control of what you're doing. So let's move to the next slide, please. And what happens is with polycarpolactone, you're mainly going to produce is collagen type 1. And collagen type 1 increases the long-lasting results and the quality of the results instead of collagen type 3, which is mainly inflammatory collagen. This is proved, which is, there's a paper that was published on that by Dr. Nicolau, and this is, in our understanding, the best quality of Ellanse is the ability to essentially produce collagen type 1 for inducing a very low-grade inflammation or a very low-grade foreign body reaction. Because, again, without foreign body reaction, we cannot have collagen production. Let's move on to the next one, please. I'm really sorry. I have no control on what I can get with my key errors to move the slides. So we get together a group of colleagues that are using Ellanse for a longer time, and what they call as experts. We're not experts. I think we just have faced adverse effects and just using for a longer time, and that's what makes us experts. We are facing this for a longer time. And what happened is, in all this paper, and we're going to move it one by one quite fast, is we try to agree or get a consensus on what we agree. And consensus between doctors, because I think sometimes I joke, say more than one doctor is difficult to get the consensus, but we were able to agree on things that we do commonly. And Vishnu, can you please move to the next one, please? And what we're going to do is very simple. We try to get recommendations how to use it. And we're going to move these slides one by one. And you got this PDF on the handouts, and you can read it by yourself. But this is what we have done. So this is the parameters and what we did. And the thing is, we compiled this document based on what we do it on our practice for the past 6 years. Can you move to the next one, please? And doing that in a table that shows you exactly how we're doing and what we not do. Can you move on, please? Just keep on moving. I'll tell you when to stop. So these are the contraindications. It's very common to all fillers. Everything is written on the paper. Never use it intradermal. The subcutaneous and the supraperiosteal placement are the most important ones. Avoid bolus, avoid high pressure injections. And again, now you're going to be a bit slower. You got this table and the anatomical areas, which instruments actually with devices are using. Is a cannula, is a needle, and the volumes that we promote you or we ask you to use, and usually they are enough to get the correction of the deformities you see. Of course, these values are just indicators because it depends on the patient, and as you know, can be high variable. But the thing is, if doing like this, you avoid complications. And again, is about reducing the pressure of injection, the speed of injection, and the quantity. It's easier to add, it's very difficult to remove. And that is a phrase that you can apply to any filler. And then you got some pictures and before and afters, the schematics of what we have done, what was used, and and they can give you as a guideline again to what you can do and what are the potentials of using a Ellanse in a safe way. Because the main reason we have done this paper was actually about safety. And again, also in the hands is it's a great product to be used in the hands because it gives you long-lasting results and is so simple in terms of technique. So the other thing is the post-treatment, and sometimes you are very consumed and very locating into what you're doing. It's but what you need to advise after. And some patients, and you're going to see some of the cases we're going to present, is have swelling afterwards. And swelling is sometimes just because of heat exposure. And when it comes to safety, and that's one thing that Sinclair does for all the products, is they got an annual report that they publish, is also on your handouts. And you can see that there's one adverse event for 1,800 syringes, and swelling and bruising are included in there. The most common one are lumps and nodules. Lumps is not a medical term, so I'd like to stay with nodules. And it's actually the most common one, because for me, swelling, well, normal swelling and bruising is not the complication of the filler, is a result of the treatment. And we can move to the next one, please. So we think the best way of getting things done is training, training, training. And this is not a product that we should start with. If you are coming into cosmetic practice, you're starting using fillers, start with hyaluronic acid, then move on to Ellanse once you got your hand done and you got experience. Because again, it's not because hyaluronic acid is safer, or it's not because you have an antidote for hyaluronic acid. The simple reason is hyaluronic acid doesn't last as long, and you can speed this resorption in case you need. But the most important thing is you gain control of what you're doing, and you get a better eye, a more developed injection technique. Can you go to the other one, please? So, and this is what we recommend. So you can go to the next one, please. So, and when you do fillers, you have to think about something. It's about anatomy. Anatomy helps you to define what you need to treat and where you need to treat. And you can sell so many cadaver courses, you can go for so many lectures. But the thing is, when you get the face like this in the topographic anatomy, where you want to place your fillers is where it's necessary to place, and which is usually it's at level 2 in subcutaneous, or level 4, which is on the deep retaining ligaments and space, where you got the deep fat compartments. You can go to the next one. And this is just a very recent publication about the superficial fat compartments. And they have done some MRI studies with the heads standing up. And the thing is, they found out, for instance, that layers number 1 and 7, when you stand up, the volume goes down to the lower part of the compartment by your position 2, 3, 4, 5, and 6 stays where you place it. So this is the mechanism why you get a nasolabial fold and why you get the jowl when you age. Can you go to the next one, please? So you don't want to get these areas full in a superficial plane, because you're going to get it worse. So the same thing is about comparing the mobile and non-mobile areas. Again, it's the same reason. You have to treat, if you treat a mobile area, you have to go probably deeper. But if you go a non-mobile area, you can work in different ways to be able to stretch it. Can you go to the next one, please? Sorry. And then you have to work with the ligaments, because the ligaments are the most important thing you can have. And they're actually not the most important, they're the most predictable thing in the face in anatomy, and they're the most stable structures during aging. So if you work with the ligaments, for instance, if you work over the zygomatic, or so the pre-auricular area where the ligaments are quite stiff, you can just, with a small amount of filler, doing a lot of lifting and a lot of volumizing. You go for the next one. So the idea is sometimes you look to the anatomy to look, and the next one, please, to look to things that have to avoid arteries, but actually you can use anatomy to plan your treatment in a better way, and using the lowest amount you need to get the best possible result. So again, where are the safety places? It's level 4, level 2. Remember, we can get to the next one. Arteries and veins are usually at level 3, which is when you got the muscles. And when you see the aging, you can see that these deep fat compartments suffer some atrophy, and at the same time, the ligament support to them is lax because they are both supposed to be movable areas, so they age faster than other areas. So you need to ask the next one, please. So when you get these complications, we need to define in 2 things. One thing is an adverse event. Another thing is an unwanted cosmetic result, can result from overcorrection or misplacement. That's not an adverse effect resulting from the filler. It's something that results from our treatments and you need to avoid. Can you go for the next one, please? And revision, you can go faster now, and I'll tell you when to stop if it's necessary. So what's happened is early complications are these ones. The most common one, the most common ones are not vascular occlusions, are actually swelling and bruising. And that's what you need to be careful with. because that's the most common. And vascular occlusions can be other things. And you go back to there, swelling. Sometimes, and Dr. Shengli is going to address it with Ellanse, swelling can be a bit more persistent in certain areas, especially in the periorbital area because of the, can you go to the next one, please? Because of the lymphatic blockage. And this is a patient I treated. She was a heavy smoker, and be aware of smokers. Everything goes bad, usually worse with them. And this is what you treat it. You can use just a massage, which is my first line of treatment. You can go for locally the injection of steroids. Early days with Ellanse, it doesn't work much. Surgical removal, I think, is just hypothetical. You don't need it, honestly. Can you get to the next one? Actually, scarring can get it worse, so it's something for us to avoid. Remember about infection. Can you go to the next one? And infection is about, it's our care. We need to clean and treat people like we should. This is a patient that come to see me after AJ's fill injection with multiple abscesses because they use a leftover over lips without changing the needle. Can you go for the next one? After drainage, things go back to normal, but she has some hyperpigmentation, which is resulting from inflammation. So you need to be aware of this. The next one, please. And vascular occlusion. The thing is, there are no zero risk areas. We're trying to concentrate and to say what's the anatomy comes, because we're starting looking at the anatomy after you got cases of blindness and necrosis. It should be the opposite. You should look at anatomy before you got the complications. You are reverting things. And this is totally technical dependent and knowledge dependent. And the thing is, you have to look into the patient and say what is worthwhile doing. And if the risk increases and the benefit decreases, don't do it. So that's why, for instance, areas like labella, you have to be very, very careful. It's for me, it's a contraindication. No, you don't use Ellanse on lips, you don't use Ellanse on eyelids, but you can use it on a supraperiosteal level to treat the same areas if it's necessary. And again, it's about technique. Get a bigger gauge cannula, 22, 25, low pressure injection, small amounts of each time. And if you can use some infiltration with epinephrine to reduce the problem of complication in terms of intravascular injection, just do it. But remember, there's no risk, zero risk areas. Can you go to the next one, please? And this is just a phrase from a book I took. This is a patient that come to see me from treating another doctor, and that was using a 27 gauge cannula. It's too thin for this area. And can you go next, please? This is not Ellanse. This is, but again, it was the necrosis was there already. And this is what you again have a scarring effect on that, and you can go for correction. The next one, please. But even with the correction, there'll be always a scar. So again, this is about prevention, is about foreseeing things. And in my opinion, the wrong thing here was too much. The cannula was too thin. And the 27 gauge cannula is a dangerous cannula because you cannot control the tips because of the flexibility. So be careful with that. It's more related to the device that you're using than to the fillers that you're using. And the other thing is about facial arteries. And these are the typical 5 types of facial arteries that you can face. And can you go on to the next one? And the most common ones, you don't know exactly what it is because this is 4 studies that were done, 3 studies actually that was done, and the 4th one was presented, is the angular artery is not the most common one. That's what you were teaching anatomy classes. Apparently, the ones that have more cadavers, it was 100 cadavers, the first line, 44% were actually the lateral nasal artery and not the angular artery. So we need to be aware that variation is the most common thing. Can we move to the other one? And we need to use these fillers on the safe areas, which is layer 2 subcutaneous or layer 4 deep fat compartments. Can you go for the next one, please? And this is a CT scan, actually MRI from the face. Just one back, please. And just depending on the facial artery, on your left, you got the facial artery, on your left, on the right, you got the venous component derived from the facial artery. So it's very, very difficult to get your needle or cannula there, not touch anything. So just be aware of it. The next one, please. Well, pain is a very important thing. And if you treat dangerous areas or more prone to risk areas, please follow up with the patients in the first day. If something is there, you can act. If nothing is there, everything is fine. There's no discoloration, everything is fine. It's just a very good marketing tool to your patient. It just means that you care about them. And in terms of ischemia, you can treat with everything you have. It's an emergency. So I do use hyaluronidase because it increases the permeability of the veins and arteries. Sometimes I do use nitroglycerin gel if I think it's more about a venous injection. And you can also use other things like sildenafil and aspirin to do that. But the most important thing is follow up with your patients and act as early as possible before you get to necrosis. Because once you got to necrosis, like the picture I show you, is about wound care, it's about debridement, it's about surgical reconstruction. And there's no coming back from there. Can you go to the next one, please? So again, remember about ophthalm. This is very rare, but it happens about injections into the ophthalmic artery. So be careful, it's internal carotid system. We need to be careful, and there's a protocol, the next one, please, that was published recently. And there's one thing I got in my clinic, is this one. And you can, then in the end, you're gonna have the webinar, so we can go back to these ones, is what you need to do to work in case of an emergency, ophthalmology emergency due to the fillers administration. So just go through this. This is very, very considerably, and this is what you can do. Can you go for the next one, please? So in conclusions, I think this is the most important part of it. Is face anatomy is a complex, don't forget about that. Different layers and variation is the rule. The internal carotid system is mainly taking care of the upper third and periorbital area, facial artery, the lower and mid thirds. And there's a bit rich anastomotic network that can bypass eventual blocks. That's why the complications, vascular complications are very rare. And the thing is, the most important, the most difficult, the most dangerous layer is the number 3. And the most important thing also, when you're going to do is fat pads and the anatomy change with age. So the displacement of soft tissue occurs with age, and you have to be careful with that. You have to pay attention to that. What something looks well in a young patient cannot be the same thing in an old patient. Can you move to the next one, please? So the delayed ones, usually I'm going very fast here, is mainly what we're looking for is for granulomas. And granulomas don't know why they come. But nodules and granulomas are different things. Nodules is what you mainly have with Ellanse, and is a very, very rare thing. But nodules, and I think Dr. Shangley is going to address this in more detail, is usually a technical error. It's the wrong fill in the wrong place in the wrong quantity. Granulomas, you still don't know why they exist. It's a matter of every filler, every substance can induce granulomas. Can move to the next one, please. And it's not something specific of a substance, but you know that some substance like permanent fillers are more prone to. This is actually Restlane is published, and this was a polyacrylamide, a patient of mine, and you can see that the granulomas, they show up, all of them. Every area that was injected come up with, and you can drain it. Sometimes if there's a cystic granuloma, can you go to the next one, please? And these patients, if they're cystic granuloma, I tend to drain them. This is a video just to show you how it can be. This was a bioalchemy. It was injected like 8 years before, and the patient had the surgery, and this just shows up after the surgery. So usually before a granuloma event, there's like something, a trigger event that you can actually find out. Can you move to the next one? So it's about clinical history and what you can treat for granulomas. The thing is, there are so many things in the literature. These are the most common ones that are proposed. Can you move to the next one? And these are also other ones that also were advocated to treat granulomas. So when there's so many treatments for the same identity, it can tell you something. There's not something really, really effective. So I think it comes up avoiding permanent fillers, because permanent fillers are the main cause. The granulomas are actually the most important cause of granulomas are actually permanent fillers. But all the other ones can also induce granulomas, but mainly cystic granulomas. With Ellanse so far, we have one case that is being studied, and there's another second case that also is under investigation. So let's see what it takes us. But again, it's something that it will happen in the future for sure, because it's a matter of numbers and being used. Can you get for the next one? But the rate is very, very, very low so far if you consider the amount of things that syringes were used already. So I think in terms of this is prevention and safety, it's interchangeable, and that's what you need to do. Is if you plan well, execute well, and have a good choice, but also don't forget, it's not just understanding anatomy, choosing the fillers, it's also about the follow-up, because if you don't follow up with your patient, you're never going to have complications. That's for sure. There are two sorts of physicians without complications: the ones who don't do it, and the ones that they lie about it. So I do have complications. You can move to the next one, please. So this is my conclusion. And sometimes you have to say no to the patients because it's not for them. You have to do something else, or you're not even a filler. So this concludes my presentation. I know Dr. Shangli will give his presentation, and we'll come back with two cases, one from him, one from mine, and we'll just let you know what we have done. So thank you very much. Dr. Shangli, please, it's your turn now.
Okay.
Thank you, Dr. de Mello. Now moving on to the second presentation by Dr. Shangli Lin.
Hello, I'm Shangli Lin, a dermatologist based in Taiwan. During this presentation, we will focus on the causes, the prevention, and the management of the adverse events most frequently seen in our daily practice. In the post-market survey published in 2017 of 490,000 syringes of Ellanse, the most common adverse events reported clinically were swelling, lumps and nodules, inflammation, infection, bruising, hematoma, and induration. I myself also reviewed the patients that I've treated during the past 3 years between April 2015 and May 2018. Among 1,267 patients treated with a total of 6,078 syringes used, the average syringes number per patient was 4.8, and the most commonly observed adverse events were swelling, bruising, delayed onset edema of the midface, and non-visible lumps in my database, which is generally consistent with the post-market survey. So in this presentation, I'm going to discuss the most frequently seen and the most concerned adverse events in our daily practice and their cause, prevention, and management. Generally, the adverse events of dermal fillers are classified by the time of onset. For those that occur up to several days post-treatment are early events, including injection site reaction, infection, hypersensitivity, irregularities, skin discoloration, and vascular events. And for those that occur from weeks to years post-treatment are defined as delayed events, such as atypical infection, foreign body granuloma, migration, and immune reaction and persistent discoloration. Persistent scarring and malar edema. For the 5 most common adverse events I'm going to discuss in this presentation, bruising, swelling, and discoloration belong to the early events, while nodules, granuloma, and malar edema belong to delayed events. All dermal fillers have the potential to cause bruising. Bruising is observed more frequently after injection into the subdermal plane using fanning and threading techniques. Less bruising is seen when materials are injected using the depot technique at the pre-periosteal level. Bruising of large areas can be disturbing to patients and cause dissatisfaction to the treatment. Many patients prefer to keep a low profile in terms of their aesthetic treatment. However, too evident bruising can put them in a very difficult situation and make them hesitate for future treatments. So prevention of bruising to these patients are far more important than the management we provide them. It is important to review the patient's medication history and avoiding all blood thinning medication starting 1 week prior to the procedure. During injection, a slow injection technique helps to avoid vascular injury, especially when we pass through layers of soft tissue to reach the supraperiosteal region and thus reduce the bruising rate. In soft tissue, the use of a blunt cannula is good to avoid bruising. In my experience, oral arnica montana tablets administered 20 to 30 minutes prior to injection and immediate compression by my assistant while I'm still treating other parts of the face helps so much to reduce bruising. If the bruising occurs, the patients usually should be instructed to start warm packing a few times a day, starting 24 hours after injection. Topical onychomontana is also helpful. If the patient comes back for a follow-up visit a few days after the treatment and have obvious bruises on the face, I prefer to use topical onychomontana gel and increase the penetration by sonophoresis in my clinic to speed up the dissipation. Other basic instructions to the patients include sun avoidance as long as bruising persists, no vigorous exercise for the first 24 hours to avoid raising blood pressure. Many users have tried to place products superficially in the little junction to correct the tear trope and to treat fine wrinkles of the face. However, if the periorbital region, in the periorbital region, Ellanse is not only contraindicated, but such discolored lesion may occur. Apart from the Tyndall effect, one of the often common discoloration events frequently discussed would be xanthelasma-like reaction that occurs in the periorbital area. When the product is inappropriately implanted too superficially into the subdermal and muscular layer, a yellowish hue may occur mimicking xanthelasma. Cases have been reported in PLA, HA, calcium hydroxylepatide, and PCL. Some of the reactions are frequently coupled with focal telangiectasia. The precise mechanism is unclear. It may be related to binding of low-density lipoprotein and internalization by macrophages according to their common microscopic features. To date, there is no effective methods of elimination, so prevention is the best solution. For Ellanse, avoid placing the product in the periorbital area and placing it too superficially. In the malar area, it is always better to place the product supraperiosteally or in the submuscular level in small amounts. As a matter of fact, in the aging process, volume loss occurs mainly on the bony structure and in the deep fat compartments in this region, and it makes better sense to restore the volume accordingly. If unfortunately this does occur, some may resolve spontaneously, and in the literature, managements to this reaction as the way we manage xanthelasma are also recommended, such as 5-FU injection, TCA solution, or CO2 dermabrasion. Nodule formation, if any, could be related to the injection technique used by the practitioner, mostly due to too much of the product injected in a single point or placement of the product in a hypermobile level of depth. The majority of nodules disappear spontaneously within 1 year. If the nodules are non-visible, waiting for its spontaneous resolution is an option. If the patient feels uncomfortable with the nodules, follow the protocol of the visible nodule management may help. As opposed to the nodules, granulomas are more immune status related in nature, with relatively smaller amount of the product in the lesions and more prominent inflammatory signs of the patients, such as swelling, tenderness, induration, local heat, or even purulence. This patient had a distant history of granulomatous reactions to calcium hydroxylepatide, and the granulomatous reaction still occurred when the patient was treated with hyaluronic acid in the preauricular area. The chronic intermittent flares of swelling and erythema didn't completely heal until hyaluronidase was used in combination with intralesional 5-FU and low-dose triamcinolone. In the second patient that was treated uneventfully with a high and low molecular HA, 3 months later, a painful granulomatous reaction occurred, 2 weeks following dental work. In this third patient, the presentation of granulomas occurred 6 months after injection of calcium hydroxylepatide along the jawline. And in this patient, the granulomatous reaction that occurred after a urinary tract infection presented 6 weeks after the last session of PLA injection, with flares of treated sites simultaneously. A skin test with PLA was then placed on the arm of the patient to illustrate the systemic nature of the reaction, and this indicates when the patient is prone to the granulomatous reaction, the reaction could occur everywhere in the skin. In this report of granuloma, due to Ellanse published earlier in this year, induration of all the injection sites occurred simultaneously. The biopsy was consistent with the granuloma. However, the history of predisposing factor was not clearly described in the article. From all the cases shown in the previous 2 slides, we understand that granuloma could occur after all kinds of filler injections. Distinct from nodules, the histopathology of a granuloma shows an overabundance of reaction to the product with too numerous to count foreign body giant cells. Granulomas have been reported with all currently available commercial devices, including collagen, hyaluronic acid, PLA, silicone, calcium hydroxylepatide, PMA, and a polyacrylamide gel. The occurrence of a granuloma are usually host immune related. In the cases of granuloma we shown earlier in the photo, the test in the patient just showed that if the patient is in the immune sensitive status, the granuloma just can appear anywhere. As granulomas have often been used incorrectly in reference to papules and nodules in the medical literature, we practitioners should clearly know the difference with regard to their causes, features, and management. Under the examination with the microscope, a nodule is distinct from a granuloma. The histopathology of a nodule revealed an overabundance of product, while the histopathology of a true granuloma shows an overabundance of host reaction to a small amount of product, indicating the latter is immune origin. True inflammatory granulomas are rare, and in clinical practice, with injections of steroids and anti-metabolites such as 5-FU rarely recurring after treatment. As illustrated in the figure on the left, Ellanse can be used in almost all facial area for volume restoration and facial reshaping. However, to avoid nodules and papules, the product is not suggested to be used in areas such as the periorbital region and lips. In addition, glabellar injections increase the risk of intravascular placements of the product and thus is not suggested either. Regarding the management of visible nodules, if the lesion formed between 2 weeks to 3 months of injection, the idea of management in this stage is to redistribute the product. So the nodules may be flushed intralesionally and broken into smaller pieces with saline to facilitate its degradation. If a nodule forms beyond 3 months after injection, intralesional injections of corticosteroids repeatedly with the dose of 1 to 4 milligrams per lesion are performed every 2 weeks until the desirable result is achieved. In the early events after Ellanse injection, swelling and edema is the most common reaction that takes place soon after the treatment. Normally, the first few minutes to approximately 20 to 48 hours after the product is placed, swelling erythema coupled with induration limited to the injection site are usually observed. From 48 hours to a few days after the product is placed, there is less induration, usually no erythema, with the remaining reaction being mainly diffuse edema appearance of the patient. Full resolution can be expected within a few days to weeks, and the intensity is possibly volume related. In some cases, the patient can have a stronger reaction than average, and reaction like this can be managed by the oral prednisolone. This 48-year-old female was treated with 2 cc Ellanse for nose and brow reshaping. Severe edema occurred on the second day after injection. Neither signs of vascular occlusion nor signs of infection were noted. After 3 days of oral prednisolone 10 milligrams per day, edema resolved. However, if the patient has a history of facial implant, injection at the implant site has been listed in one of the contraindications. The adverse event usually due to the injection at the implant site can be lasting and tricky for management. This 32-year-old female had a history of nasal implant. She was treated with 0.3 cc of Ellanse on the nasal bridge 6 years after the implantation. Severe edema occurred a few days after the injection and lasted up to 8 weeks. After 2 weeks of oral prednisolone 10 mg per day, edema improved only moderately. So the swelling region was then managed with intralesional steroid injection. After 2 sessions, 2 weeks apart, the swelling completely resolved. One last adverse event for today worth our attention would be malar edema. Quite a few cases have been seen clinically for the past few years. Malar edema, different from the acute edematous reaction after the treatment, is a delayed reaction that takes place weeks to months after injection. It has been reported with all fillers when injected into the infraorbital hollow and tear troughs. Such edema was defined as a clinically significant degree of swelling that lasted more than 1 month following injection. The occurrence of malar edema is due to lymphatic compression caused by the product that occurs superficial or deep to malar septum. If the compression occurs superficial to the malar septum, it is seen as infraorbital edema. And if the compression occurs deep to the malar septum, cheek edema predominates. The incidence of malar edema can be reduced by proper patient and filler selection, limiting filler volume, and by placing filler material deep to the malar septum at the immediate periosteal level. This 30-year-old female looked perfect 2 weeks after 1 cc injection on each side of the deep medial cheek. Acute onset swelling of the cheek took place 6 months after injection. This is a typical case of lymphatic compression by the product and the subsequent formation of the host on collagen. Treatment of malar edema caused by a non-hyaluronic acid filler recommended in the literature includes head elevation massage to keep a good lymphatic drainage, nighttime taping and daytime pressure, oral steroid hyaluronidase, intralesional steroids, and disruption of any nodular material. In my personal experience of managing a few cases of malar edema, I believe intralesional steroids combining mechanical disruption of the nodular material with a cannula helps the most. This 48-year-old female experienced progressive cheek swelling and a few lumps and bumps close to the bilateral lymphatic junction 5 months after placement of Ellanse, 1 cc on each side in the deep subcutaneous plane of the infraorbital area. This patient was referred to me for management not long after swelling occurred. Those palpable nodules are managed with intralesional steroids at the dose of 4 mg per lesion by mixing 0.5 cc lidocaine and 0.5 cc of 40 mg per cc triamcinolone. I got 20 milligram per cc in each syringe, which allowed me to inject 5 points with each syringe. For the area close to the lymphatic junction and the fat pads of that area, I used the 25 gauge cannula to dissect as much as I can to disrupt the nodular area and created as many spaces as I could in the engorged plaques to relieve the compression. The images on the right side, taken 48 hours after the first session, showed significant reduction of edema on the cheeks, and the swelling completely resolved 8 weeks after the second treatment session. To wrap up, I want to emphasize some of the important details that could help us prevent the adverse event. In terms of the injection techniques, we need to place the product nicely in different levels of depth by adequate injection techniques with adequate amount. Always inject slowly and never overcorrect. To avoid adverse events other than lumps and bumps, in-depth knowledge of anatomy and physiology of the major facial vessels and nerves is always the key. Here we listed a few conditions with which patients are not good candidates for Ellanse injection, as these conditions might increase the risk of unanticipated complications. Do not treat patients with autoimmune diseases, pregnant or breastfeeding, using steroids, with uncontrolled diabetes, with metabolic syndrome, showing any signs of infection or showing any contraindications as noted in the IFU. Contraindications of Ellanse injection should also be kept in mind to avoid undesirable side effects. These include the patients with related allergies and hypersensitivity, keloid, and the areas that already have permanent implants. In conclusion, slow injection, cannula use, compression after injection, and use of arnica montana is helpful for bruises. For several edema that occurs days after injection, oral steroids should be considered to relieve the edema. Nodules are managed differently before 3 months and after 3 months, and should be distinguished from granulomas, meloedema. Meloedema can be prevented by avoiding the relevant anatomic structures, and if it happens, intralesional steroid with mechanical disruption could be beneficial. Thank you.
Thank you very much, Dr. Lin. Dr. de Mello will now present some cases. So I will change presenter.
Thank you. Thank you, Dr. Shanley. Great presentation. Really educative and very, very clear. Thank you very much. Well, I have just 2 cases to show you, and I try to get this in a very clinical setting, sampling this case 1. And these were cases that are not mine. They reported to me, and I was, because they came from far away, I was not able to really assess how the treatment went, and I just have the photo that was sent. So excuse me for that. So the first case, it was done using Ellanse L, and there was induration that became more and more evident after 6 months after injection of Ellanse L. And the same thing happened in the tear trough and in the mid-melee area. So can you get to the next slide, please? So when I got these cases, and these are the photos, you can see the area on the temporal area. The next one, please. the next one, and on the theatroph and on the mid-malar area, the next one, please. So, and another one, and you can see the temporal area also. So you can move to the next slide. So when I got reports like this, these are the kind of questions I do, because I think it's what we need to be able to answer. And because you don't get answers for this, it's going to be much more difficult to treat or to propose a treatment. Because one thing is treating our own patients, another thing is advising someone to do it, and we are not in the ground to be able to assess it and to manage it. So my first question is about how much was injected, because this clearly, it was too much volume in the wrong areas. And it's not just the volume, it's how it was injected. And it looks like, in the case like this, everything was done by bolus. This is a typical doctor that came from hyaluronic acid and jumps immediately to Ellanse L, which is not advisable, using the same technique that he or she used with hyaluronic acid, which is a bolus technique. So we need to be adapting our technique to the product you use. You cannot use the same thing for every single filler. Then it was about the mixing, and the mixing is very simple. It's when you mix with lidocaine, you call it mixing because you're just using 0.2, which is what you can recommend, because without changing the gel qualities and properties. If you do more than that, it's not Ellanse anymore, it's something else. And in this region, when this patient was treated, there was this tendency to dilute it because it's a little bit that comes from using of polylactic acid, and also is an advocate for the uses of calcium-hydroxylapatite with radius. Is about diluting it. Thing is, as I told before, you don't need to dilute. There's no reason. There's nothing logical and practical that you need to do that, or it's even not advisable because it is control. Then the other question is what was done in the same areas, because most of our patients have done treatments or are going to do treatment somewhere else, and any other treatments done at the same time, and trying to find what we call was any trigger event, anything that created this. But typically, these are very well defined things, and they look like nodules. Can I have the other slide, please? And so the possible causes are overcorrection, bolus technique, definitely for both. Superficial placement of Ellanse, definitely, I have no doubt about it. I didn't have no answer for the off-label use, but in the periorbital area, in the lower eyelids, I think that was what was done. So how do you correct? What do I advise them to do? And they can get the next slide. And so this is for what I do for nodules. I prefer to use methylprednisolone instead of triamcinolone. I do the reconstruction, and I get like a dilution of 20 milligrams per ml, and I use 0.1, which comes to 0.05. It comes to something between 1 to 2 milligrams per area, and depends on the size of the nodule. The thing is, for nodules, what I think, and I agree with Dr. Shangley, the mechanical breakage of the nodule is important. And this is one reason why I mix with hyaluronidase also. It facilitates the penetration and of the product, but it's not to melt anything else. It just facilitates the way I go. And I do repeat this at 2-3 weeks interval, and we need to continue until the inflammation is settled, usually around the 4-6 months, because remember, this was Ellanse L. You might need to repeat it again, and you have to be careful with the side effects of the steroids, which is a bluish discoloration, some telangiectasia, skin and fat atrophy, and that's why I don't use as much triamcinolone, and I prefer to use methylprednisolone. In situations where there are also some inflammation, if it was not the case, I can use oral steroids. This is a question I have commonly is about the collagenase, and I don't have experience. I don't have availability in the UAE, but what I know is collagenase is mainly directed to collagen type 3, and it's not have a good action of the collagen type 1, which is the main collagen that Ellanse will produce in the long term. So the effect of it will be really, really small, theoretically. Can I have the other one, please? Case 2. Well, this is a case where clearly there was a dilution 1-to-1. So they were not using Ellanse anymore, using something else. microdoses, subcutaneous, and we got the persistent swelling and erythema that evolved to pigmentation, and the swelling disappeared after 4 months, but discoloration is still visible. Can you move to the next one, please? So what this is the case. Another one, please. And you can have also an audio there that is not reporting on that. Because again, it's too, and you can see the injection was too superficial. That was the bolus. Now my question is, why you dilute it? And I got always the same answer, is to make it weaker. It doesn't make it weaker, actually make it less predictable. And it was placed too superficial. So what do I advocate as a treatment for this? Can you go to the next one, please? And it's very simple. The causes, the post-inflammatory pigmentation, all that comes, gut inflammation is something you can always have, but overcorrection and also lymphatic drainage impairment. And this is one of the cases of persistent medullary swelling that can take time. But it's always resolved by itself, even if without treatment, but the pigmentation can always be a problem. And as Dr. Shengli said, also some telangiectasia can show up. Can you go for the next one, please? So, well, you can use a lot of things. In my hands, I do use a lot of topical cream, especially hydroquinone and retinol. I always start with mechanical massage, and I teach the patients how to do it. And that usually gets a very good improvement on the swelling. And on the case of the nodule, definitely you need to use intralesional steroids. And you can also use a broadband light to improve the pigmentation and even the telangiectasia if you need to. And I think this is my slide, the last slide. So we have some Q&A now, and I'm going to ask the moderator, Ralph, if you can put the both together. Shengli, are you hearing me?
Yeah.
Yeah, I got a microphone. Okay. And we have a couple of questions. And well, we're going to do like this. You're going to respond alternate, and you'll comment on over each other if it's necessary. And I'm just going to read our first question, and we'll take it from there. What do you think? Okay, so I got the first question here, which is a very simple one. Can I get it? Is after a strong massage after the injection, will it be helpful to prevent an nodule? What do you think?
Usually I mold after injection, and I think the idea and the most important part is that when we inject, we need to also make sure we inject small amount in lines or small amount in deposition to make sure we don't have too much of the product in one small point. I think that's the most important. As long as the product is distributed evenly, I think strong massage or not is not completely the key to avoid nodules or granuloma.
Well, I agree with you. I think it's more about how you place it, more than how you distribute it after you place it. I think it's more about the technique. It's about fanning more than bolus. And of course, you can massage it, but if you massage it too heavily, you're actually going to create swelling because of the mechanical trauma you're going to use. Yeah. So I think it's more about predicting how much you need, and if you distribute it well and uniform, actually increase the surface of stimulation, and gonna end up with a better result because end up with more collagen stimulation than the bolus. The patient I show with the medullary edema, again, is something I want to call the attention. She was a heavy smoker. And do you have any experience? People who smoke have more tendency to got medullary edema or persistent edema?
Excuse me, Doctores, you have some sound issue. It looks like you have the loudspeakers too loud at your computer.
Which one?
Maybe both.
Maybe, okay.
Okay.
Oh, that's better. Thank you.
Okay.
Okay. So do you think it's, let's go back to the question, it's about smoking.
Yeah, smoking. Actually, I didn't ask every of my patients with granuloma or medullary edema if they are a heavy smoker or not. but I think they do have play some role, because since the blood circulation for smokers are not always as good as the average people. So I believe it does play some role, especially for those who are already prone to edema. It's just like you already have not very good blood circulation in the central phase, so it does have some role for edema.
Yeah, it's my experience. What I notice is, well, if you go back, I always, like as a surgeon, I have to check if they smoke or not. But what I found out is, first of all, you got microcirculation deficiency, more rigid capillaries, more easy to bruise. And when it comes to lymphatic drainage, the lymphatic drainage is very, very superficial. Lymphatic vessels are 0.6 millimeters from the skin. So what happens is, it's very easily to block them with any pressure you do. So I'll be careful with massage on that area. I'll be focusing mainly on distributing the product well, and always below the orbital rim, never above the orbital rim, because then you're going to jeopardize that. Okay, I got another question here.
Dr. De Mello, I'm sorry to interrupt, but please lower the volume of your loudspeakers. It's yours.
Okay.
Thank you. Thank you indeed.
Okay, I got another question here. Is regarding the use of prednisolone to prevent edema. Because someone says that 90% of the patients are presenting edema. That is not my experience. I think edema is more related to your injection techniques than about what you're doing. Some patients are more prone to edema, but I don't use prednisolone as a prophylactic or a preventative measure to edema after my injections. What about you?
For patients who receive higher volume injection, for example, for more than 5 syringes, I routinely prescribe 3 days of prednisolone to keep to make the edema weaker in the following days. However, for lower volume injections, I don't routinely prescribe prednisolone to control the scale of edema.
Okay, when I go over, usually I prescribe a no steroid anti-inflammatory, but for the same reason, but for a couple of days. And that goes to another question that they come up is there any contraindication of using steroids? Because one of the contraindications we put for Ellanse treatment is people in current treatment of steroids. So how come we are using steroids prophylactically to avoid edema? Do you have any comment on that?
What's that?
One of the contraindications that shows up on the slides for using Ellanse is people on current treatment on steroids. And we are actually advocating for certain cases to use steroids to avoid edema. Do you feel that's any contradiction on that?
Well, I think it's not very not the most important one for me, I think. Yeah.
Okay. Well, what I think is when one of the reasons we put steroids as a contraindication for treatment is because you're going to slow down the production of collagen, so the result will not be showing as we want. But the most important thing is the reason why people are on steroids. It usually is our rheumatology or autoimmune disease, which is per se a contraindication to use Ellanse. So I think it's not the steroids, not the problem. It's the reason why they're not taking steroids that we need to assess. Okay, I got another question here. Let me just get it for you. Is about nodules. I understand you do also some mechanical destruction of the nodule with the cannula.
Yeah.
Okay. For me, I agree with you. I think we need to do some mechanical action there to be able to penetrate and to infiltrate the steroid inside the nodule. And we have to be very, very careful where we place it to avoid skin atrophy and fat atrophy. Otherwise, you can end up with a bigger problem than we start with. Do you have any, like, say, small tips to how to do it and how to avoid complications there in the long term?
Okay. When we inject intralesionally to deal with nodules, my tip is that always hold the nodules firmly to make sure you place the tip of the needle intralesionally. I think that's the most important. And when the needle is placed in the right place, you actually will feel the consistency is very different from the peripheral soft tissue, so that we can using this as a clue to make sure we are injecting in the right place. And this is also very important to avoid skin atrophy afterwards.
Yeah, I totally agree with you. And the thing is, when we inject, the resistance that
My
we
apologies.
face
We have some
to
audio.
inject
Dr.
is much,
Damelo,
much bigger. Yes?
Dr. Damelo, we have some audio issues, and I think it's from your. Do you have a chance to use a headset?
Okay.
Yeah, I can change to the headset.
Okay. You can hear me now?
We can hear you, but we have some echo, and I tried to mute
Okay, so
one of you if I was speaking. We can give it a try.
If you can mute Dr. Shengli for a moment, I can go back to the next question, and I can answer that, which is with the other things we can recommend for other measures to avoid edema after the treatment. Again, I think we covered a couple of them already. It's about quality of the injection, how you inject. It's the ability to distribute it and be as atraumatic as possible, respect anatomical plans, and of course, you can have other measures that are non-invasive, like ice packs. I do a lot of ice on my patients. I recommend to apply ice packs over the face after the treatment, sleeping with a pillow, an extra pillow during the first night, even taking, if it's necessary, a non-steroid anti-inflammatory or a steroid, depending on what you want to treat. But these are the most common measures. But other measures like not being exposed to heat, and believe me, by living in Dubai, that is one of my first measures. Stay indoors, don't go out, or if you go out, well, be careful, be a moderate exposure to heat and sun. Avoid intense physical activities in the first 24, 48 hours for the same reason, because your blood pressure will go up. You're going to have more swelling afterwards and more risk of having bruising. So these are the main things that you can, but there's very, very common things that you can apply to anyone, depending on the quantity. But the usual swelling you have after Ellanse treatment is actually not bigger, not more dramatic than with hyaluronic acid or another substance. It depends a lot on the technique and the pressure of injection. Okay, we have another question here. It's about granulomas and nodules. You're with us, Shengli? Yeah.
Yes, I'm here.
I think you touch a very, very sensitive issue. Is you need to be able to diagnose what you face. Nodules are something, granulomas are another thing. Different causes, different treatments.
Right.
So for you, what is the most important thing in terms of diagnose when you distinguish one from the other?
Okay. Usually, the picture of the patients with the granuloma to me is that when the patient shows up, he or she stated that he has multiple indurated swelling lesions in the previously injected area. Usually these lesions occurred simultaneously. So when signs like this occurs, usually I prefer it's a granuloma. Usually nodules is not very swelling, not very painful, and it is always in small numbers. So when all of it's sudden onset, then I prefer it as a granulomatous reaction.
Okay. Do you do any tests to differentiate between those?
The actual way to make sure the diagnosis is always the biopsy. So I usually it is not always easy to persuade the patients to take the biopsy. So I usually begin with clearly taking the history, carefully taking the history to make sure if there is any reason like dental work, like recent history of recent infection. And I check the time of treatment, and if there is any previous history of granulomatous reaction in this patient. So by collecting all this information, it does helps a lot to make sure the correct diagnosis. And for nodules, usually it occurs almost within 6 months of the treatment. So when it occurs, it is usually much earlier than the granulomas.
Well, I agree with you. It's about clinical history, definitely. And I think when you're looking for granuloma, usually you can find a trigger event, something that starts that non-specific immune response. And well, I found out so many different things from infection, dental work, sometimes simple things like changing medication for blood pressure can I've noticed, and it can happen. The thing is, with a nodule, usually it's very, very well defined. Boundaries is something you can really localize, and is a very early onset, and not everything at the same time. I tried the superficial ultrasound scan to be able to distinguish between them. One is a cystic lesion, usually can be helpful. And we can, because nodules are not cystic, they are hard things. So it can be something that helps you in terms of the differential diagnosis. But you need to have a very good and experienced operator of the ultrasound. Otherwise, they'll classify everything in the same way. And I face the same problem when I send things to pathology, because the moment the pathologists see a foreign body, they always classify it as a foreign body granuloma, because also the pathology is not aware of the difference between nodules and granulomas. So I do think the most important thing in terms of differential diagnosis is the clinical aspect, is a clinical diagnosis that can be confirmed by histopathology, but the diagnosis should be clinical in that sense. Well, we have another question here, is regarding, again, the swelling. I think we are really going on the swelling. This is from Dr. Nero from Australia, and he asks us, because he experienced the same kind of reaction with some of the hyaluronic-based fillers. And he asked if you think it's a kind of immunogenic response, and that can also happen with Ellanse. What do you think?
Let me see.
Because I faced with hyaluronic acid, some of the late swellings and rebound swellings you might have can be related to endotoxins. And that depends a lot on the purity of the gel. When it comes to Ellanse and more synthetic fillers like Ellanse and Radius, for instance, that is not the problem, because we are supposed not to have endotoxins, except because there's some human manipulation during the manufacture process. They can have some contamination, but it's a very, very, very low grade. So I don't think it's related to that. It's probably more related to the local inflammation that actually are creating for a foreign body reaction that you are looking for collagen stimulation. I think the mechanism behind it is actually totally different from AJ's.
Yeah. So I usually for Ellanse, the edema after injection, well, for me, there are stages of tissue reaction. For the first few days after injection, it's usually more swelling. But several days after the injection, it's usually more like diffuse erythema, diffuse edema, instead of significant swelling after the injection. So I think the stages are different in different time point. So that's also a clue for us to distinguish if there the differences.
Okay. Well, we have another. I think we still have time for a couple of questions. I have one question here from someone who sent it. They have a granuloma from Ellanse M, and is doing a protocol treatment already, but there's still some persistence. I think, what else do you recommend? I think, first of all, is if you have any adverse event, I think you should report it to Sinclair. Because it needs to be investigated. I think the nature of it is I think that's the tonic of what you're discussing here, is establish a very good diagnosis, because we still are facing issues, and most of the complaints we are facing about granulomas are actually not granulomas, they are nodules. And I think, first of all, you need to understand exactly what it is, because if you start doing interlesional steroids injections, or if you put the patient oral steroids, both of the lesions can actually improve. But nodules, usually there's not much of an improvement with that, unless you do some mechanical traction. Right? So I think the therapeutical approach or the therapeutical test should not be applied here. You should have a diagnosis beforehand before you're doing anything. What do you think?
Right. Yeah, I totally agree. Yeah.
So, any other questions we might have from your side? Because I think I got all of them from my side so far.
Yes, I have seen. I think the questions I got here is pretty similar from where you have.
There's an elephant in the room that we need to address. There's always, when you ever talk about adverse events, it's about the vascular problems.
Mm-hmm.
And people sometimes approach us and saying, okay, when you have a vascular problem with the hyaluronic acid-based filler, you just flood it with hyaluronidase, and that's it. Well, I totally disagree with it. I think vascular problems should be avoided. Definitely need to treat them when they happen. But hyaluronidase is not a panacea to cover everything. It doesn't. It's not an antidote. It doesn't. And the most viscous and more transformed hyaluronic acids that we have now in the market are actually more resistant to hyaluronidase. So, and the other thing is hyaluronidase expands with water. So inside the blood vessel, it will expand and is more prone to have a blockage or embolism than probably carboxyl that doesn't retain too much water. I do the same thing. If I have a problem there, I just flood everything with hyaluronidase. I got my aspirin in. I got nitroglycerin gel. I go with everything. I don't hold anything back because I think it's an emergency, and you have to do whatever you can to treat the patient. Do you have any specific thing that you do when facing one of these problems?
Okay. Like you mean like nodules or?
No, a vascular issue.
Okay. For me, I have to say, usually it is very important to know where the vital vessels are and how to avoid that. So for when I have been using Ellanse for more than 3 years. For the supraperiosteal region, I use sharp needles to place the product. But for subcutaneously, I prefer to use a cannula to place the product. So by doing these and placing the product in small amount or aliquot, I have been, avoiding adverse events like this quite well. So yeah, I think this is very important to avoid adverse events like this.
Okay, I think we reached the end now. And
we have one final question here.
Okay.
Have either of you ever injected in the tear trough area?
Well, let me tell you. Let me rephrase that so I can answer it. I do inject in the supraperiosteal area, close to the orbital ring, but not superficial in the tear trough. And I use that for Ellanse, and I use that for the other fillers.
Yeah.
I don't inject in the eyelids. The skin in the eyelid is attached to the muscle. There's no fat there. So even the physiopathology of a tear trough is not superficial, it's deep. So if I correct it deep, I'll be safe and I'll be able to correct the problem.
Yeah.
That's what I do.
Okay. Yeah, if we take a look in the aging process and the formation of the tear trough, I think bone remodeling plays an important role. And the support of the bone changes when we age. And also if we want to place the product subcutaneous, it is usually the defect pad in the mid-face that we treat instead of the periorbital region that we should place the product. So at the periorbital region, I always place the product deep on the bone instead of superficially or subcutaneously.
Totally agree with you. You should address the problem, not the consequence of the problem.
Right.
Excellent.
So
nice. So that was a good word now to end, I think. So I want to thank you very much, Dr. Demelot and Dr. Lin, and thank you everyone for attending today's Ellanse webinar. If you have any other questions, please use the contact form of the Sinclair College Please note that this webinar will be available on demand in the Sinclair College webinar section within the next few days. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of Sinclair and our presenters, thank you for joining us today and have a great rest of the day.